probably forgot everything I lectured on Friday because I focused on GU. This is really just a male anatomy class. I mean, at least my slides are better than looking at that. I've had to lecture that in the past. It's interesting. But come on, diagnosis of pancreatitis. What are we looking at here? Diagnosis of pancreatitis. So now that stuff works, right? So A, everybody's good with that, right? Strict ulcers, you have a reason for that. That lipase is diagnostic. So if they're going to have that abdominal pain, you'll get that down. You're like, I just took a test. He's giving me another one. That's not cool. So we have our absolute indications for why we admit somebody. This person has never had this before, claims to never have it before. So first bout of pancreatitis gets what? They get admitted. Because we need to figure out why. Figure out why. Remember I told you about the 83-year-old lady, silicone implants, intubated, sour ICU. These are older people, these have comorbidities, these are really sick people. So a lot of people get their nose done, a lot of celebrities. That doesn't mean they're going to have acalculous cholecystitis. And STEMI, not that serious. But somebody with third-degree burns on 45% of their body, yeah, that's bad. That's bad. Those are the people that get sick with this. So A is your answer. Good on that? Clear? So you're going to get a mix of stems. You're going to get some stuff like this, and you're going to get some stuff that's a one-liner. You're just going to get a mix of it, but it all works out as far as timeline. 60 questions, 4 sessions, 240. Don't have to crush it, you just got to pass it. So what is this? We talked about that circadian type of thing, which happens at midnight. So already good with biliary colic. Probably going to progress to chronic cholecystitis, if not an acute onset. And if it's acute and they have cholecystitis, where do they go? Not home, from the hospital, in the hospital admission. So both of those are going to have right upper quadrant pain. Both of them can have leukocytosis. Both of them could have an elevated lipase or BUN. But what's going to separate that? We know there's a blockage. So jaundice. Everybody good with that? Jaundice. I'm going to tell you something else is going on. Alrighty. So I already gave you your video of your upper GI bleed with the homeless alcoholic guy. So this happens a lot, unfortunately, in the emergency department. People come in. It's obvious when they're bleeding from the upper because they're talking about vomiting blood. Most people don't look in the toilet every time they go to the bathroom, so they're not always going to see that. What they usually complain of is when they wipe and they see something. So upper GI bleeds, just a little bit more about this. So upper GI bleeds, in my opinion, a little bit more concerning. And this is near and dear to my heart. And I tell you that because I lost my last 2 living grandparents, my mom's mom, my dad's dad, 92 and 88, both upper GI bleeds. Okay? Non-operable if you make it that long. Not going to do anything. Transfusion, cool. Nobody's going to put him in the OR when they're that old, unfortunately. So, but 92 and 88, I'm not upset about it. It's kind of weird they passed 2 days from each other from the same thing. Again, my mom's mom, my dad's dad, not, you know, some people when they get old and pass, the other person follows. But again, very concerning. We've got to figure out where the blood's coming from. Upper GI bleed a little bit more concerning, but lower GI bleeds can be the same thing. So, getting into that. Reference material. A whopping 3 pages in technology on upper GI bleeds, lower GI bleeds, chapter 75, 76. Anybody have a technology home? You shouldn't. I'll never do that. There's another version that's 2 volumes. But if you make it to professor status, you just call up the company and they'll send you a free copy. Good deal. Thank you for the paperweight. All right. Causes. Obviously, we're going to look at evaluation, management, and then disposition. This is pretty standard stuff. So, again, not everything's an emergency with this. Most of these folks are going to come in. You'll see what an emergency is. They're vomiting blood profusely, and then you've got to temporize. We'll talk about those things. But not all these are emergencies. But they are concerning because you can't just see the bleeding all the time. They can be bleeding internally. The lower GI bleed, the guy that I always had that would come into Madigan, I saw him 3 different times. He would come in, lower GI bleed, and he was having a type 2 in-stemming. What is that? What's a type 2? Remember back to cardiology, you guys dump all that already? Good answer. So type 2 is supply and demand. This guy's having an in-stemming because he's bleeding so bad. He's hypovolemic. He's not able to perfuse his. So it's not a matter, we're not going to put a stent in him. We got to transfuse him and get that bleed to stop. Type 2 in-stemming. You come in every time, troponin through the roof, just bleeding internally. So acute and severe GI bleeding. Think about your shock, make sure you're looking at your vitals. So upper GI bleed, sweet. All right, here's what we need to know. They ever ask this. Upper GI bleed proximal to the ligament of Treitz. Ligament of Treitz. Everybody look at the slide there. They may kind of mix it up on you on your pants and say, well, it's bleeding above the... All right, everybody look to my left. Man, I'm trying to get one for the sophomore class. For the senior. It's probably overheating. All right, cool. So ligament of Treitz, also known as the suspensatory muscle of the duodenum or duodenum. Potato. So just realize it looks like a very small percentage. Yeah, Western countries, this is more of a Western issue, first world problems. But yeah, you look at that tiny percentage, that comes out to 0.0172. Yeah, when we talk about 330 documented people in America, that's a lot of people that could potentially be coming into your ER. So, again, right here, variations in Helicobacter pylori rates. So we know what causes that. So socioeconomic conditions play a role in this. And then we also have been able to help this and hurt this at the same time. We have medications that can treat ulcers, but we also give people medications that cause ulcers. So high dose NSAIDs, people that are taking just popping Motrin all day long, which is why please don't prescribe 800 milligram Motrin, it's worthless. If you get past 600, don't mess around. So increasing age, obviously, we have organ system disease, so other comorbidities, and then people that suffer from recurrent hemorrhage. Why? Because they're older or because they are anticoagulated, which puts them at higher risk. So we treat people that have had strokes, we treat people that have had heart attacks, we treat people that have had thromboembolisms with anticoagulants. Yes, it puts them at higher risk. We don't want them to fall down, get a bleed. We also, unfortunately, they bleed inside. So what's our most common cause of upper GI bleed? Make sure you know this. Upper GI bleed. Upper GI bleed is peptic ulcer disease. Number one. That can be 4 different flavors. You have your esophageal, you have your stomal, gastric, and duodenal. So be aware, yeah, there's people that are on aspirin. And what are most old people on? At least 81 milligrams baby aspirin a day. And NSAIDs, and of course smoking. I think we've gone more away from that. Verdict's still out for vaping and other nicotine products. And we're identifying this quicker. How do we diagnose H. pylori? Well, wait, there's 2 different ways. You can do a blood, you can do a breath test, right? So, and then a lot of times these people need a scope and they go and take a sample, send it off, check it out. So despite this downward trend in the last 20 years, this is the most common GI bleed, but we need to identify that and treat it. So what do we typically treat H. pylori with? So I'm not going to get into this right now, so we got to give them some type of And it's going to calm down their stomach acid, and then multiple antibiotics to get that under control. Because when that ruptures, that can be a big deal. Or ulcerate. So here's your other types of issues. So all that are common causes of GI bleed. That's gastritis, esophagitis, duodenitis. That's secondary to peptic ulcer disease. There's your predisposing factors. Obviously alcohol being the big one. Salicylates. So if somebody has this problem, they're adding Pepto to it. It's not actually helping the issue. So I usually stay away from Pepto and go with something called Carafate. Pretty familiar with that? Much safer than adding salicylates to the mix. NSAIDs, and then we have all these infection, toxic ingestion, sometimes involuntary, most of the time voluntary. So stress, so make sure you have somebody who's coming in a peptic ulcer, you find out they're working 3 jobs, they have 5 kids all under the age of 2, yeah, that's gonna, it's possible. I'm just saying, just be aware of that, make sure you're asking those types of questions. And then these people that are ventilated, we worry about that as well, being a risk factor. So, now we talk about gastric varices. So portal hypertension, most commonly from alcohol, result of alcohol disease. So, kind of varies a little bit, but if we're talking about a patient, and I'm going to give you an example, I'm going to say this person doesn't drink any alcohol and they have an upper GI bleed, hands down, peptic ulcer disease. History of alcoholism, we need to jump to, and I say that cirrhotics, just a generalized term for people that have issues with their liver because they drink too much. Upper GI bleed 59% of the time. 59% of the time. If they have a large history. Everybody understand how portal hypertension works? So your body works overtime to get the alcohol, to take care of the toxin that alcohol is. So it's going to work overtime. These people are going to have high blood pressure, but they're going to have portal hypertension. And that liver is working really hard to take care of the body. So I just tell them to shut up, you're fine, right? Too early? Okay, I get it. But here's something that I definitely saw in my pantry. Just be aware of this. Something called the Maillard-Duey syndrome. You got to separate this. This is not something that's super concerning because it is just a longitudinal tear versus Boerhaave, which is really bad. But classic history, repeated vomiting. Who do we see these in? Younger people that have been drinking, diabetic ketoacidosis, because they vomit a lot because it has to do with the prostaglandin and abdominal pain, and then chemotherapy, unfortunately. So be aware that can also happen from Valsalva, whether it's coughing, straining, seizures, also a reported cause. But longitudinal, this is a big one for the pants. So you need to be able to differentiate between that and something that's even worse than this Boerhaave. You're not going to see that in a younger person. So we see that Hammond's crunch, chest pain, shock, subcutaneous emphysema. Make sure you're doing good physical exam. You're not going to catch that. That is a complete rupture. That is horrible deal. So causes forceful vomiting. So unfortunately, yes, this has happened in childbirth, seizures, weightlifting, and then especially in somebody who's decided to ingest something corrosive. Here's some other outliers. So AVMs, arteriovenous malformations, malignancy can be other causes of this, and then you need to pay attention to this. So if they have an aortic graft, we're very concerned, aortic graft, that they have an aortoenteric fistula. So this one, they'll kind of lead this up to you in your test question as a herald bleed, meaning it starts out slow and these people just tank after that. Massive hemorrhage, exsanguination. Exsanguination, another word for somebody that just completely bleeds out. That's not good. So it can be in the vomit, can also be in the stool based on how quickly their GI tract. Just be aware, I've had a couple of people that say I'm vomiting up blood, and then I go and look and they have a posterior nosebleed. Significant posterior nosebleed. And I call ENT versus calling GI. Call GI for a nosebleed, yeah, I just lost my credibility. Just lost it. Not good. So make sure you check the HENT. It can be above, it can be below. Make sure you check those things, ear, nose, and throat. be going on there. Take a good look in the back of their throat. If you can see blood draining down, not probably coming from the GI tract. So, coffee ground emesis, hematemesis, melena. So melena, just give us an idea. Could it be from the upper? It could be from the lower. Depends on the patient. So upper GI bleed, usually vomiting bright red blood. Hematemesis versus coffee ground emesis. It digested a little bit and came back up. So vomiting, retching. If they've been retching a lot and you're younger, we can probably rely a little bit more on a bowel device care. Make sure we're doing good HPI. Past medical history, yeah, if they've had, like I told you about the gentleman, it was like his third time that I saw him. He's like, yeah, I have lower GI bleeds. I'm like, cool, you check your troponin again. Sure enough, instantly, let's bring him to the hospital. He's going to get a scope. He's going to get a scope. We know it's lower GI bleed with that, but let's make sure that we work that out. So again, aspirins, history of steroids, NSAIDs, any anticoagulants makes a big history of that. So again, we were about our alcohol abuse. Hence, the homeless guy that I showed you from day one says, I'm vomiting blood. I'm really concerned that guy has some varices. That could be a big deal. But I don't know. Maybe it's peptic ulcer disease, no history of alcoholism. Can you have a history of alcoholism and it's not varices? Sure, it can be peptic ulcer. Remember, that's your top one. And then we have our erosive gastritis, people that just continue to put bad things in their bodies. So there can be something called simulated melena. Be aware of that. You bring a kiddo in, and the mom's just been giving them Pepto, so, or ingestion of iron. That can also mimic that. Certain dyes that are in foods, so drink a bunch of red Gatorade and you're already having diarrhea, can come out the same way it went in. Just be aware of that. So stool guaiac, we don't do a lot of those, but you can do that bedside. Some of that, they prefer that it go down to the lab. It used to be back in the day, you had the chemical, you put on it and test it right then and there, but that's not the case anymore. The lab wants to take control of that, so just be aware of that. So bright red, maroon, rectal bleeding. So that's why we check back there. If it's darker, it's probably an upper GI bleed, but we get worried about that. Maybe it's going really quick, so bright red or maroon. Melena. Anybody smelled melena before? Tell me, yeah, it's a very distinct smell. Melena, C. diff, and gangrenous diabetic foot. That'll clear the room. So pay attention to those smells. So might help you out. What smells like almonds? Oh, we'll get into that. Blockade. I'm still at thunder. So keep in mind, not everybody's going to tell you those types of things. You better try and figure that out. Make sure you get a chaperone and you go in there, you take a look, you do a rectal exam. You get a chance to do that this year, but pay attention to what symptoms they're having. What symptoms they're having. So they're hypotense, tachycardic, that means something's going on. Are they septic or are they bleeding somewhere that we can't see? Angina, so chest pain, that's that type 2 NSTEMI. Weakness, confusion, cardiac arrest, consider that maybe it's a GI bleed. So, especially as they get older, they don't typically look back in the toilet again. It's going to be, I wiped and I saw something. Again, rectal bleed, hemorrhoid, lower GI bleed, diverticulitis, upper GI bleed, peptic ulcer disease. You need to know those things. So visual inspection of the vomitus. So I encourage people to bring that in so I can see it. I want to see how much, I want to quantify that. So sample of that. So when I call a GI doctor, I'm like, this person, I think they have an upper GI bleed, I have this much vomitus, can you please come down and scope them? So vital signs, hopefully, but it can be very early. So just keep in mind, these are older folks, so they're probably hypertense all the time. They live at 180. So when they come in, you're like, oh, they're great, they're 120. Systolic, it's not good. It means they're bleeding somewhere. So decreased pulse pressure, difference between systolic and diastolic. If those are closer, no bueno. So tachypnea, so just be aware if somebody bleeds inside their belly, they can have paradoxical bradycardia with hypovolemia. So just be aware of that. So, and maybe they're older, they're on medications, they're on a beta blocker, they're on this and that. That's going to mix up your clinical picture. So that's why we make sure cool, clammy skin, so signs of shock, or orthostatic hypotension, or vasovagal, just be aware of that. And then the other ones that give you away that an alcoholic, spider-angiomas, pulmonary edema, jaundice, gynecomastia, yep, enlarged breast, not so obvious in a woman, but very obvious in a man, so suggests liver disease. And then we make sure we check the skin. Check the skin, petechia and purpura. So how do we know it's purpura? Push on it, right? Okay, does it blanch? Nope. That's concerning. It's concerning. It should blanch. So again, that ENT examination. I had a lady that had moved just from Korea, getting treated for chemo, got a posterior nosebleed, and came in as a 2. They're really worried about her. I looked in, all the bleeding was coming from the upwards down the back of the oropharynx. I gave her oxytazoline, freaking balloon tamponade, did everything I could, and I had to call ENT to come down. They took care of it. They went back in there, put some crazy whatever they do, but they got all the cool cameras and headsets and took care of it. So make sure we look, perform a rectal exam, make sure we do a good abdominal exam on these folks. So your exam is going to come into huge play here. So make sure there's no masses, society's organomegaly, and then we look back to quantify what's going on. So rectal bleed, I want to make sure there's no fissures, make sure there's no hemorrhoids, quantify the amount of bleeding that's going on there. So I can tell them, yeah, they're bleeding profusely from the rectum. Very concerning, whether that's red, was it maroon, is it more melanic, more with melena? Okay. Single most important thing to look for if that person comes in right here. So let's get a cross and match right away. Because we think we're going to have to give them a transfusion. It's going to fix the issue. Just keep in mind that maybe really early they come in. These are first world problems. People come in early, they don't have to worry about a copay, especially in the military, they're going to be in there early. Get that taken care of. What we want to also watch is look for that BUN level. So that's going to come from a BMP. So BUN is going to give us an idea if there has been some blood digested in the GI tract. That BUN is going to go up. Keep in mind, it can be very early with that. And we want to make sure we get our coax studies, because most of these people are going to be older, or they're going to be alcoholics, which means they have liver disease, or they're taking anticoagulants. We need to make sure that we get that PT, including an INR. Now, we used to check a lot of INRs back in the day. What do we check INRs for? What type of anticoagulant were people on that an INR is super important? Warfarin, yeah. We've gone away from that. Now we go with these factor 10 inhibitors and whatnot. They used to have like coag clinics, and I went through phase 2, and they'd come in and be like, oh, how much leafy greens have you had this week? Because that just messes up that vitamin, up to vitamin K, right? And that's how we usually treat warfarin if they've had too much for that type of bleeding. Anyway, we want to get an idea of at least their baseline and go back and check. And then again, like I told you about that type 2 in STEMI with that gentleman, yeah, ECG. Didn't show any ST elevation. Didn't. That troponin was through the roof. So silent ischemia, want to make sure we're checking for that as well. So yeah, that can cause some decreased perfusion, whether that's in the belly or the heart. So again, get a lactate on these people. If you have an older person that's not doing good with GI bleed, just throw the kitchen sink. Especially when you're starting out, I want you to cast a wide net. I want you to catch these things, and then tone it back. Like, I don't have to order a lactate on everybody. Get your nurses upset to do that. Don't do that. So routine abdominal chest X-rays, limited value. Again, I'm not downplaying X-rays. I'm just telling you in the ER. Unless it's a trauma, we're not ordering anything really stat as far as X-rays. CTs are more important, but we want to be very careful. We're not ordering any PO contrast because it's contraindicated. So if we can't get an endoscopy done, there's potential for tagged red cell scintigraphy, tagged red blood cells. So we're going to figure out where that bleed is. That's going to help us temporize, especially in pediatrics. What's the one thing I told you that we check for, especially with GI bleeds, especially in a kiddo, non-painless, mom finds blood in the diaper, Meckel's diverticulum. Okay, and we're going to get tagged red cell scintigraphy. So they can help localize that and decide whether or not they want to handle things surgically or medically. How can we handle that medically? What's one medication that we use on the battlefield? TXA. Yeah. It's a great go-to when you can't figure things out to temporize it. It's not going to solve the problem, but it's going to help us get before things go bad. So there's potential. I had a lady that came in. She said, I've been vomiting blood, handfuls and handfuls of blood. That's a red flag on paper. I said, cool. She was a little bit of a hypochondriac, whatever. But guess what she got? NG2. Guess what? Zero blood. Made me very reassured. She didn't like it, but you know, is what it is. So positive aspirate, very strong. So these people come in, it's okay. Don't worry about doing any damage. Don't worry about you're gonna make the varices worse. It's okay to put that NG2. When you call the surgeon, you call the GI doc, and you say, yeah, I put in an NG2 and a massive amount of blood, he'll be down a lot quicker. So visual inspection, most reliable. That's why I tell people to bring that in. If your kid has a seizure, please bring me some video. You have a phone for a reason, take some pictures, let's bring it in. It adds a heck of a lot more credibility when I get on the phone and I got a battle with somebody. So potential to do a gentle gastric lavage. So we don't do a lot of these anymore. It's been done a few times, but make sure we're not using cold water. Not using cold water, room temperature water. Make sure you're doing that. And then don't worry about putting that NG tube. You're not going to make varices. You're not going to rupture it. It's okay to do it. So here's your predictors of high risk. So obviously the older they get, comorbidities. So how bright red that vomiting of blood is, or spitting up of blood, or it's coming up bright red on the other end. So instability, obviously. We need to know their past medical history. So if they're an alcoholic, have they had any variceal banding in the past? Have they had any ulcers in the past? So have they had a TIPS procedure that says alcoholic? So you're thinking, man, ulcer bed, that's older people. No. I had a 26-year-old coming through Ranger School that kept passing out. I sent him to the ER. They scoped him. Peptic ulcer disease. 27 years old, but he had a history of it. 2 units of blood. They went in, did some cauterization, took care of it. And he graduated Ranger School. Was able to recycle him. But just keep in mind that it can happen with anybody. So here's your very low risk and your high risk. I'm going to tell you right now, I will send somebody home, but they have to hit every category in that left box. That left box, not, yeah, whatever. So high risk. So any one of those is lit up. Yeah, they're not going home. They need to be admitted. You need to fight for that. So patients in the low risk category, they have to meet all those criteria. So I think it's funny, it's advanced stage. Apparently that's anything older than 60. I don't know if they have a lot of comorbidities. They can be a lot younger and have issues with that. So what do? We take the ER approach, make sure we're doing our ABCs. Can't get to the C if we have A and B issues with. So 2 large bore IVs, not the little 20 that they put in on that homeless Army guy. Activate your massive transfusion protocol. Ooh, what criteria do we have to do that? Well, your spidey senses are going off, but I can tell you right now, you use your ABC score. So pulse is greater than 120, systolic under 90. You can do an EFAST, and that'll tell you that's obviously we see free fluid in the abdomen. That's concerning. But then penetrating trauma is the other thing. So I only need 2 of those, and I'm going to be activating my massive transfusion protocol. Now you'll see different things based upon your MTF in phase 2. The BAMC moves a lot quicker. Level 2 trauma centers moves a lot quicker. It'll be frustrating, but just be aware. Don't get behind the power curve. Start ordering type and screens. Get a type and cross that at least gets an O negative. Make sure you handle that airway and potentially get some fluids going as you're temporizing and waiting for the blood bank to bring up the blood that they need. So smaller doses of induction because they're hypovolemic. What does that mean? So how much etomidate do we usually give somebody? Everybody's seen like the shows ER, right? So 0.3, 1.5 of sucks. So it all works out, usually 30 and 150 for your standard, okay? We're gonna do more like 0.15 etomidate. You be careful with these folks. You don't need to tube them, tank them. So just have an idea of that. Everybody watch any ER show that they do it all the time. By the way, it doesn't happen every shift like that, whatever. There's just your breakdown. Be careful. We want to transfuse. We want that sweet spot of 7 and 9. 7 and 9. You can get an eye set and get that back really quick, like within 5 minutes, and not waiting on the lab for an hour. So make sure we're checking that coagulopathy. We don't look at transfusing platelets. Please, people still get it wrong in my phase 2 test until it's under 50,000. Under 50,000, then we're reaching for platelets. Above 50,000, we're going to temporize, pressure, all that stuff. We do not transfuse platelets until it's under 50,000. For ITP, for bleed, for anything. So omeprazole is what we get on board with, because we need to calm that down, because they bleed worse when they're acidic. So get that under control. Octreotide, especially in our alcoholics, and then antibiotics. Why? Because they're higher risk. Higher risk. We're doing like a big dose of omeprazole, 80 milligrams IV stat, and then reaching for Cipro, ceftriaxone, especially in our cirrhotics, because why? They're immunocompromised. We're drinking way too much. So upper GI bleed, blood transfusions, master transfusion protocol. We talked about the ABC score. So transfusion can be difficult at these times. So transfusing these patients, hemoglobin, if they're above 9, we got to be careful. It can do some harm. We're going to give them too much blood. It's not a good thing. So it overloads the heart, the lungs, and the kidneys. We give too much blood. Be careful with that. That's why we want that sweet spot between 7 and 9. Between 7 and 9. Most patients, obviously, are older patients. We're going to be careful. Be careful. So if we know that they are anticoagulated, we need to reverse that. We need to reverse that. So unless there's any contraindications, whether that's cardiac or any type of stent, so just be aware of INR. Greater than 1.5, so higher the INR, less coagulation is happening. Be concerned about that. So do not be right there, TXA. Unfortunately, the book answer says doesn't do a great job. That's the book answer. Well, you're going to be doing stuff by the book, but you're also going to be doing stuff that you think's right. And if we're at a point where we've tried everything else, and TXA is the last thing to reach for, we're going to go for that. So book answer, no benefit. Book answer, no benefit, but keep some things in your kit. As you move on with medicine, you'll start learning more about evidence-based medicine and things like that. You have to start making decisions and figure out what studies support the decisions you make. So, treatment, proton pump inhibitor, PPI, high dose. So we want to make sure we're keeping that gastric pH at a normal level. So why? Because clots don't form if it's acidic. Higher than 6.0, we're going to have issue getting clot to form, which means they're going to continue to bleed. So get that PPI. As soon as they come in, I think I have an upper GI bleed, a lower GI bleed. I've already ordered the omeprazole, 80 milligrams IV. I want to get that going as soon as possible and do that across the board. So high dose PPI right there. Omeprazole, 80 milligrams. I'm not going to test you on the dose, but I need you to know you need to reach for omeprazole. Now, omeprazole orally doesn't work that fast, but IV it does. So make sure to look at that. People with peptic ulcer disease, and I don't care if they're having variceal bleeding. I haven't figured that out yet. I'm just going to start this because it's better to start it early than wait. Look at that. Reduce the need for surgery, length of hospital stay, and signs of bleeding. So by giving that, you're actually saving, not just saving the hospital money, but you're saving that person's life. Saving that person's life. Now, what do we reach for? Worried about variceal bleeding? Octreotide. Octreotide, analog of somatostatin. So threefold, it stops the gastric acid from being secreted, similar to a PPI, so it's going to help clot formation. It's going to reduce blood flow, so less blood is good, and then it causes something called splenic vasoconstriction, which is not 100% understood, but it just means that it helps out. So no clear benefits, but we're going to get it going. So when you still haven't figured it out, go ahead and let's get both going. We're not going to do any damage. better do something than sit on it. And then the third thing, let's make sure that we get antibiotics on board. Again, I told you alcoholics are immunocompromised, so impaired immune system. We want to make sure that we're taking care of that. Reduces infectious complications, going to decrease mortality, start as soon as possible. And 2 different flavors. If you're on the fence between either of those, you can definitely ask whoever's going to admit. But most of the time, I usually sell an admission because I say I've already started all these things. Octreotide, IV, I've given PPI, omeprazole, 80 milligrams, and I've started my antibiotics. It's very hard for somebody to tell you they're not going to admit the patient when you're doing all these things that can only happen in a hospital. So sometimes you got to sell it, and it's the right thing to do. If they're going to be scoped, there's potential. You pick up the phone, you say, I'll be down there to scope them, upper GI bleed, no problem. Hey, do you want me to start an erythromycin, a metoclopramide? Which is your flavor? They'll be like, man, you know what the heck you're doing. You sound like you're on point then. Why, it's going to help out with the endoscopic visualization. So not recommended. That's why I asked, hey, do you want me to start these? So just be aware, large amounts of blood in the GI tract. What do we need to do with these people that need with an upper GI bleed? Yeah, they need a scope. Hopefully you're in a hospital or you have somebody on staff right then and there. Again, if it's 5 o'clock and you know they're going home, I go and give them a call and say, hey, I'm pretty sure I got an upper GI bleed. You may not want to go home and start dinner yet. Just doing you a service. Sometimes they get upset. I don't really care. I don't really care. So early endoscopy, maybe as long as they're stable, go into the hospital, look at the scope the next morning. We'll do the temporizing stuff. We start the PPI, maybe octreotide, plus or minus, and definitely antibiotics, and they go and they stay. So make sure we're taking care of that. There's potential that they do come down right away if they're unstable, and they're going to scope them right away. Because they can do some diagnostic and therapeutic stuff. Maybe take care of that and figure out exactly what's going on and why they're bleeding so bad. So here's what they can do when they do endoscopy. So they can do ligations, sclerotherapy, where they inject those sites. So clips, they can cauterize that. Again, injections, epinephrine. So there's potential that you're there that you may be the one that provides the sedation for that. If they didn't bring down their staff, I can't tell you the number of times where I've done conscious sedation or whatever so that they can reduce the shoulder. They can do the same thing here. Usually accommodates the safe thing to go with. Remember, they're bleeding, so they're hypotensive, so we need to lower that dose a little bit potentially. So antiemetics, the last thing we want to do is deal with somebody that's vomiting when they're getting a scope. So fentanyl and Versetta propofol, kind of older school, we've kind of gone away from that. But old school, yeah, we want to make sure it's not comfortable, so we're going to treat the pain, but we also need to make sure that we're putting them out. So Versed, probably a bigger thing than fentanyl when we used to do a lot of elective cardioversions. So what do we cardiovert somebody for? So AFib potentially, as long as it's unstable. So SVT if it's unstable. Cardiovert somebody that's, what's another weird one? We've got to be careful with the young people that we don't. Be careful. Watch out for that WPW. So 23 years old coming in and they're freaking SVT, it's probably WPW with AFib underlined. Be careful cardioverting those people. What do we reach for? What medication? Come on, you guys gonna have to know ALS at some point. Per kg, right? 17 mg per kg. Yeah. Remember, don't freak out when you're doing ALS. Why? It's a mannequin. A lot of people lose their shit in there. So it's a real person. Okay? Again, we reach for cardiovascular stable medications in the form of etomidate, ketamine, very safe. If they're suffering from hypovolemic issues, and just be aware that sometimes, yeah, we'll see. You guys do IV lab. There's always at least one vasovagal or a DOT lab. Just be aware. It can happen at any time to anyone. So just be aware that you don't want to become a patient. Fall down and hit your head and you have to go get a CT scan. No fun. What can we do? Temporizing. Right here. Balloon. Tamponade. balloon tampon on. This is a temporizing thing just to get them taken care of, just to get them high rate of complications. This is the last ditch effort. So we're literally going to put a tube down their throat and see if we can get this to calm down. Look at all the different adverse reactions that can happen with that. So based upon that being where it's not supposed to be, and we inflate a tube, we can have all those issues. Should intubate these people. Now we have two different styles of these. Make sure when you get to your ER in phase 2, should be hopefully a later rotation. You're going to do 6 weeks. If you're not getting it in 6 weeks, maybe do some more. Please go on the weekends. I know it sucks to be away from your family, your kids, your friends, whatever, but that's where the good stuff happens. Okay? Good stuff doesn't happen on Monday morning. That's everybody that didn't want to go into work or they're hungover, okay? Good stuff happens on the weekend. Friday night, yeah. People's stupidity is what keeps us employed in the ER. Most of the time. But again, so Blakemore and Minnesota, know where those are in your ER, so in the event that you have to reach one, you're not running around like a chicken with your head off. It's already a stressful situation. Let's not do that. Just for your visual folks, here's how it works. So that's a Blakemore. So you're going to insert it, inflate it with sterile water, gentle traction to pull that back. The last thing we want to do is have that big ball somewhere in the esophagus and cause a rupture, make an already bad situation even worse. So just keep in mind these patients cannot swallow. It's very uncomfortable. You need to get some stuff on board. That's temporizing because we need to get surgery on board. So they can do all types of different procedures. There's variceal bleeding. They usually reach for that tips. And then potential that they can do that non-shunt operations. Non-variceal bleeding, yeah, embolizations. They could potentially get in there, this is crazy, and do a gastrectomy. So remove part of the stomach. Anyway, uncontrolled bleeding, you're temporizing as much as you possibly can. Much as you possibly can with that. So, disposition, upper GI bleed, obviously go into ICU. And needs to get that endoscopy sooner than later. Very low risk, again, they hit all the categories in the left. They're under the age of 60, vitals are fine. You haven't seen any evidence of hematemesis. They just said they had it. Potential that they can go home, but again, strict return precautions, So, all right, lower GI bleeds. Again, 3 more pages to pursue. Do I have any questions on upper GI bleeds? So you're going to temporize that. We're going to treat that. We're going to treat them both pretty similarly because, you know, that ligament of Treitz, maybe it's just below that. Maybe it's just above that. I don't know. I'm going to kind of treat that the same way, but if I'm sure that it's an upper GI bleed, that endoscopy is what we're going to do. So there's potential for angiography and whatnot for a stable patient, but if we're worried about that upper GI bleed and more concerned and they're unstable, endoscopy is going to be key. Pretty good on that endoscopy. So scope. So lower GI bleed, distal ligament of Treitz. Distal. Again, doesn't look like a lot of people. We talk about 36 per 100,000, but again, 330 million in the U.S. documented right now. So, but just be aware of upper GI bleed's most common cause when detected in the lower GI bleed. We don't really know. Unless they're vomiting blood, upper GI bleed can present the same way as the lower GI bleed. So, most common cause, again, please differentiate. If I say rectal bleeding, I'm talking about hemorrhoids. If I say lower GI bleed, I'm talking about diverticulitis. These people are probably going to present with lower left abdominal pain, because that's where the GI tract. Most of these folks know this is what's going on. So then you have followed by colitis, polyps, malignancies. That's why we get a colonoscopy at what age? 45 now. 45, right? I know because I got one a couple years ago. I mean, I'm going to get one a couple. Never mind. So 80 to 90% of these resolve on their own. Spontaneous. So again, I tell you, a little bit more concerning for upper GI bleeds, but they can all do the same type of damage. So metapesia versus melena. So bright red or maroon colored rectal bleeding. So if it's originating from an upper GI bleed, it's probably a brisk upper GI bleed, and that's not good. That's not good. It's bleeding quickly. So just be aware of can also present with vomiting of blood and hemodynamic instability. So melena, we talked about that. Very interesting smell. It's usually going to be mixed in with the stool, not streaking along like a hemorrhoid would be. Just be aware, usually slow bleeding from a lower GI source, along with slow colonic, meaning we're not having the quick peristalsis that we're potentially used to. Diverticulosis, how does that usually show up? Usually painless. Usually painless when it's diverticulosis versus diverticulitis. So erosion at the artery of that, it can be massive. These people can have severe pain. So good thing is 9 out of 10 of these resolve on their own, but about 50% will show back up again. So usually in the left colon, right-sided, which is where we see a Meckel's in a younger patient, is likely to bleed more. What do we worry about with these older folks? So they can't tolerate that blood loss. Their other organs cannot tolerate that blood loss. So you get concerned about those. They need transfusions. They're likely anticoagulated because they're older, but they're likely taking NSAIDs because they suffer from chronic pain and they're just used to taking medications. So, not to be confused with this, vascular ectasia, which is going to be probably, if we talk about that, number 2, so AVMs or angiodysplasias of the colon. So usually in the small bowel. So if they're in the large bowel, it's a chronic process. It increases with age. And then unfortunately, if they have underlying valvular heart disease, it puts them at higher risk for that. So these are fragile, prone to rupture. So versus ischemic colitis, most common cause of intestinal ischemia. We're worried about that. Usually comes and goes. So unfortunately, poor circulation, high bacterial content. These are going to be older folks. This has to be made. When I say endoscopy, that just means they get a scope. That can either be an EGD, which will go this way, or a colonoscopy, and we go through the rectum. And if you get them at the same time, I call it the rotisserie. Yeah, rough test this morning, rough weekend. I look forward to that every class. Say that. All right, 20% of these, 1 in 5 needs surgical intervention. Risk factors, there's all your risk factors. I'm not going to test you on that, but just realize that comorbidities make people higher risk for these types of things. This is an older person disease. I'll finish off with this one, mesenteric ischemia. I talk about pain out of proportion. This is pain out of proportion on exam, POE. So when I say that, I worry about a compartment syndrome, I worry about necrotizing fasciitis, and I worry about this guy right here, mesenteric ischemia. We get a lactate on these older people. Like exam, you're pushing on their belly, but they are in extreme pain. So they've had some type of thrombosis, embolism potentially that's going on. A lot of these people have underlying atrial fibrillation. They're anticoagulated. They throw a clot right in the mesenteric artery. And it just starts killing bowel. Bowel just starts dying because it's not getting perfused. Pain out of proportion on exam. Please, please, please know those 3 things, but especially for this mesenteric ischemia. So it can mimic other things, but again, pain out of proportion on exam. I'm going to let you guys take a break because I'm going to work on my jokes. What about pain out of proportion? I brought up a couple things somebody asked me at the break. I'm just saying I want you to start making some connections. And the pain out of proportion thing, mesenteric ischemia. If it's in a leg, it's a compartment syndrome, usually arms or legs, or a necrotizing fasciitis. And those are medical emergencies. Because how do we take care of a compartment syndrome? Fasciotomy, necrotizing fasciitis, that goes straight to the OR, and they're going to try and move whatever's freaking necrotic and nasty. And so that can happen anywhere, just be aware of that. All right, here's our risk factors. Greater than 60. 60 seems to be the mark, for whatever reason. That's officially old versus based on technology. AFib, why do they throw clots all over the place? Especially in the abdomen. They can throw a clot to the kidney, cause a renal infarction. So CHF, recent MI. So pain after eating is postprandial. Pain after eating, unexplained weight loss. CT, is what we're going to reach for. So we're going to go more, we do that endoscopy for the upper GI, but there's potential much more for angiography. If we're worried about an ischemia, we need to get angiography on board. So prognosis is poor, unfortunately. Look at that, survival of 50%. Half of those people are going to pass if we don't catch that within the first 24 hours. There's our Meckles that I talked about that relates back to embryonic tissue, so we typically see this more in kiddos, pediatric population. So peds, I don't know if Dr. Klein talks about that. So ectopic gastric tissue secretes enzymes, erodes away the muscle wall. This is a surgical fix. Just very rare, but realize pediatric population. So here's our other causes. So any type of colitis there, ulcers, trauma. Inflammatory bowel disease, which comes in two flavors. We go back to GI last semester, where I had very short time to burst and learn all that stuff. Luckily, we have Mr. Mercer that's teaching that now. So inflammatory bowel disease, we talk about Crohn's and ulcerative colitis, okay? Higher risk polyps, again, those are early carcinomas, and then potential after they remove those that can cause delayed hemorrhage up to a couple weeks. But again, I say this because people still get it wrong. Rectal bleeding, hemorrhoids. Lower GI bleed, diverticulitis. So usually rectal bleeding is not significant because people complain of, I saw some blood on the toilet paper. Here's your differentials for lower GI bleeds. I'm not saying you got to memorize all those, but you should kind of start rank ordering them, like what's most likely based on my patient's presentation, based on their history of present illness, based on their demographics. Start figuring those things so you can at least have your top five. At least your top five. So, yeah, I think it's very interesting. And then foreign bodies. Yeah, that happens. So, whether they're putting stuff in or they swallow things, so body packers does happen. I see it a little bit more in a border town than you're going to see elsewhere. So, again, make sure you're bringing in the full picture. We don't just make things off vitals. We don't make things off chief complaint. We pull this whole picture in. Here's the things that are going to be high morbidity. So these are people who are going to suffer from this. So if they're hemodynamically unstable, so initial hematocrit less than 35, but let's say non-tender abdomen, that's not good. Not good if they're having GI bleed. It means they're getting ischemic potentially. And then aspirin NSAID use, higher risk for diverticular hemorrhage. So those are just a few. Obviously, if it's bolded, I'd probably pay a little bit more attention. So most patients will volunteer this, but you gotta ask them. Gotta ask them. Keep in mind, if they're older, they may not be the greatest historians. Making sure you're checking questions and you look at the vitals. So are they hypotensive, tachycardic? Hey, are you having chest pain? Did you pass out? Do you feel weak? Are you feeling altered? And sometimes they can't give you that information, but hopefully somebody is there that can. That's a better historian than the patient. So, sure, yeah, we do need to ask about pain, trauma. I do preface some of this stuff when I tell patients, hey, I need you to be honest with me. I'm here to take care of you. I'm not going to judge you, but I need you to be straightforward with me. Like, hey, well, the guy with a shot glass in his rectum, I was just walking around the house naked. Okay, sure. Don't buy that, come on. Versus the dude that walked 2 blocks with a broomstick, sticking out the other end, purped his bowel twice, and the business end was right underneath his clavicle. Sure, he's just sweeping the kitchen, right? Sure. So you have to ask people to be honest with you, and especially we're talking about SI and HI. So step aside and be like, okay, so weight loss, okay, that's why we asked that, increase weight loss. Nighttime sweats, fevers at night, so just malignancy, and then obviously history of an aortic graft. We were about that aortic enteric fistula. They love that one on the pants. Please pay attention. Maybe you might see it in the future here. And we've talked about this, all those different types of things, but that can cause that. You have your 3 flavors right there. I'm not going to go into that. just be aware of that we can have simulated melena. I think I had a question on that one as well on my pantry. So certain foods can do that. Red dyes, so Sulguag's negative, but keep in mind you take a bunch of Pepto-Bismol, it's going to come out black, it's going to look like it's a GI bleed when it's not. Those will come out negative. So do get worried about that. Again, I can't emphasize enough, pay attention to that pulse pressure, because that hypotensive tachycardia may not have shown up yet, but that pulse pressure can show up a little bit earlier, and they're tachypnic because they are hypovolemic. You need to get things taken care of. Be aware if they're older, look at that medication list. Maybe they're not tachycardic and they're not hypotensive because they're on medications for that, because they live normally faster, higher. So medical conditions, pay attention to your physical exam, look at their skin. Okay, cap refill does mean something. And then again, make sure you don't see those underlying signs that relate to alcoholism and an underlying coagulopathy, meaning that the liver is not functioning the way that it should. Abdominal exam, everybody gets an abdominal exam. Everybody gets an abdominal. Please take a look at that. It confirms their surgical history, gives you an idea if there's any ascites, any masses, organomegaly. I'm not saying that you've got to palpate everybody's liver or determine the size of it. Good luck with that. Especially when they start getting morbidly obese. Yeah, that's not going to happen. So, inflammatory bowel disease. So sometimes you're going to catch those first time in the ER. Just be aware that we're going to check all these types of things, do a good rectal exam. We need to visualize those things to make sure we're not dealing with something that's more of a rectal bleed versus a lower GI bleed, and something we can take care of. Make sure, yeah, I did have a gentleman come in and said he was having rectal bleeding. Didn't find anything on exam. Luckily, I got a UA. And then went to a CT. He had emphysematous cystitis and gas all in his bladder. But he said that he was having rectal bleeding. So for historian, though, be aware that that can potentially be coming from another source, especially a vaginal source. Or be coming from a from somewhere else that's potentially in that area. So digital rectal exam, we want to make sure we check for that. There's potential for endoscopy. I've not done a lot of these. But there is potential if you're having issues getting a good exam that you can do that. So hemorrhoids can be identified. We want to make sure that we're visualizing if we can see where the blood is coming from. Laboratory tests. Yeah, we're going to get that CBC, coags, probably type and cross if they're actively bleeding, they're hypotensive, tachycardic. BMP with LFTs is what I prefer to make sure I cover down on all of that. So just a reminder that initial hematocrit may not be reflective of that blood loss, may not be reflective. So an upper GI source, then it's being digested, has a lot more time to be digested, so we're going to see that BUN increase. You see that BUN. Again, EKG, same as with lower GI bleeds, we treat the upper GI bleeds the same way, okay? So, upper GI bleeds, we're back in the lower GI bleeds right now, but we want to make sure we get that EKG just to rule out. Plus, it's just good form in an older person to always have an EKG. So when somebody comes down to admit that person, that's the first thing they're pretty much going to grab before they walk in the room. There's usually a little spot to put that. They're going to come and look at that. And hopefully, if they're older, you got a previous EKG and you're comparing those. So for making sure there's no acute changes, always a good thing. Like, well, they're in AFib today. Were they in AFib the last month they were in ER? So good thing to be able to compare. So because silent ischemia can always occur. Again, type 2 and STEMI. To bring you back into cardiology, that's a supply and demand issue. People that are bleeding can have heart attacks from the bleeding. Again, abdominal radiograph is not useful here unless we're concerned about a perf, obstruction of foreign bodies, where we can see maybe some dilated bowel, perforation, we would see free air. Foreign bodies, obviously, worry about that more with, let's just leave it with body packers. So chest x-ray, not usually useful unless you have some underlying exam findings on auscultation. And then we don't reach for barium contrast studies, so no PO contrast, no PO contrast. Initial, so based upon what's presenting. So older people, angiography. Angiography. So pretty much everybody's going to get that. We got our younger folks or people that can't handle that angiography for whatever reason, contrast allergy, kidney function sucks. They can go to scintigraphy as an alternate. And then ultimately, endoscopy. Endoscopy is what they potentially need as the final end all to see what's going on. So angiography is going to give us an idea of how we need to handle that. Can we just admit them and we'll try and figure this out, or do we need to get some surgery involved? So look at how well that works. So angiographic diagnosis, so at least 0.5 mLs per minute. So that's not a lot of bleeding. That's how effective that can be. So make sure you're ordering the right things. Again, pediatric population or somebody that can't handle that angiography is going to get that red cell scintigraphy. That's a nuclear medicine scan. So also, if you're looking specifically for a Meckel's diverticulum, it's called a Meckel scan. That's what you'll type into the computer and that will come out. So scintigraphy, they say it's more sensitive, but keep in mind it's going to take a lot longer to do this, a lot longer. More sensitive, but can take a lot longer. Potentially you can get that if you can get it during the day. This is the gold standard. Not a lot of places have this. Madigan and VAMC are one of the few places that have that. So multi-detector CT angiography is a gold standard. If your hospital has that, don't expect your hospital to have that, but you need to have an idea. Somebody asked me like, hey, what should I do when I have my elective rotations? So I would definitely say find your TMC somewhere, work with your PA there, and then potential, get with the radiology folks and just have an idea of the capabilities. Keep in mind, that's a long time to sit in a dark room and not go to sleep. I don't know how they do it, but that's why there's always techno music pumping. But be good with those guys. Go see what they do, and ladies, just guys. In the meantime, we need to make sure we're resuscitating our patients. If they're unstable, we get to, this is an action patient, not an HPI patient. So oxygen, cardiac monitoring, get your safety net in place, large bore IVs. Make sure we start with crystalloids before the blood bank can bring everything up. Make sure we're checking our coagulopathies. We can do that with a stat, I-stat, right away. So again, we want to be between that 7 and 9, so just be aware that they can tube pretty quick. They can tube pretty quick. So blood transfusion, so if they don't perfuse, they're not doing, so we do a fluid challenge, 2 liters, and they're not doing better, we probably need to be thinking about pressors and blood product. Pressors and blood product. So again, we have hematochezia. This is just some of the percentages that come out there. So if they've had a prior GI bleed and they're anemic, you can probably rest assured they're having another upper GI bleed. So treatment-wise, early consultation for these folks for lower GI bleeds. Again, we get that angiography or we get that scintigraphy, and then ultimately they probably need to go in and do a colonoscopy. So surgical consultation, gastroenterologist, especially if it's uncontrollable. There's a time, you have no problem, where I walked in on shift and said, hey, I need ENT down here right now. Well, they're going to want to talk to you on the phone. Nope, they can talk to me in the ER. This is a case, you're worried about significant lower GI bleed, and the person is hypotense, they're tachycardic, they don't look good, they're getting altered, they passed out, H&H is in the toilet. Get these consults moving quickly. So other things they can do to temporize, flex sig. Just be aware that's only going to see distal, colonic, and rectal sources of bleeding. It's going to go in, they're going to take a look back in. Cannot identify anything more than the descending colon. So colonoscopy is what they need to do, so they can see diverticulosis, angiodysplasia. They can also do some therapeutic things. They can do ablations. So again, if they don't find anything, then, well, maybe it was an upper GI bleed. Maybe it was just proximal to that ligament detritus. Just proximal to that, and then they're going to go ahead and say, okay, we scoped them there. Not my cup of tea. I prefer that they scope me here first, then there, but, you know, just theoretically. So disposition, these people need to be admitted. These people need to be admitted. Lower GI bleed. Anytime there's a GI bleed, it's coming to the hospital. It's going in. They need to be consulted with an endoscopist. That's usually, whether that's a GI doc or a surgery doc that's trained in that. So Again, know who's going to handle things in your hospital and what your hospital has capabilities of. FAMC is going to have GI docs that probably come down and all they do is scope, whereas your hospital might have a surgeon that comes down and does the scopes as well. So be aware of those types of things. You have your variables, obviously, if they're unstable, if they've had repeated episodes of rectal bleeding within 4 hours. You're concerned if the abdomen's non-tender, you're concerned about that, aspirin use, and then, of course, if they're older, they have any other comorbid conditions. Here's your disposition, stratification. I told you they need to be pretty much in that lower or that left-sided scale before I'm going to send them home. So unless you can 100% like take a look and be like, yep, it's a rectal bleed and the hemorrhoid's right there and it's a fissure right there, and you feel comfortable, just be aware of those things to make your patients let them be outpatient. So there's just different things, so be aware of your smells, those types of things, C. diff, GI bleeds, smell, and I told you, make sure you're aware of those things. We can get into a check on learning here. Any questions on upper and lower GI bleeds? Everybody good with A, right? Hence the topic of the lecture. So where are we concerned? Is this an upper GI bleed or lower GI bleed? Most likely upper. Okay. So when we talk about upper, most definitive diagnostic therapeutic endoscopy. So that's going to be a scope. It's going to be a scope. I know it seems foreign to you guys right now, but you should get an opportunity, hopefully on your surgery rotation, or if you have a GI rotation, get with your surgeon. That we had a day where it's just nonstop colonoscopies and EGDs. And yeah, unfortunately, you saw a lot of colon cancer. It's not fun. Once you get to figure out, there is a scale on how well people prep for that. You'll have some people that go and they didn't prep at all, and they'll start 5 minutes, and it's poop central, and it's like, nope, another day. By the way, that's not a fun thing. That's the worst part about it. Put it on the toilet for like a day. Most of you are young enough that you dealt with that. Propofol's an amazing drug, though. We're going to do a countdown. Yeah, what are you going to start with? 10, 9, right? 40 minutes later, it was all said and done. All right, this is going to mess up some people. Alcoholic man. So I don't have omeprazole on there, and I don't have octreotide, so what's the third thing we would go with? Fluoroquinolone in the form of ciprofloxacin. Ciprofloxacin. They're immunocompromised. He's an alcoholic. He needs antibiotics. Some people like to pick vitamin K. Vitamin K only works if a person's on warfarin. This guy's not on warfarin. Okay? Vitamin K is not going to do anything. Now some of you are like, well, what if it's vitamin ketamine? Okay, well, no, it's not. So, fluoroquinolones. I would say all those would be potential correct choices, but there's only one that's shown to reduce, and that medication is a PPI, omeprazole. So I said study, so you gotta pay attention to that because we've talked about, okay, is it good evidence if we have photos of emetemesis? Yes, but I said studies, so upper endoscopy. So we need to see, it's gonna help confirm that it's a study. Wanna keep going? All right. He's the boss. No good videos for diverticulitis. We'll get into it I got a good one for urologic stone disease. So diverticulitis, remember what I say? Number one cause of lower GI bleed. So a whopping 25 slides here, and we're definitely not gonna have to go the full whopping. So 3 pages again. 3 pages of it now. It's your reference material there. Your objectives, and a little bit of pathophys and move on through the gauntlet. So ideally that this is set up to where you think the same way when you start seeing patients and work through that. Like here's how they present, here's how I'm going to work them up, all that fun stuff. So increasingly issue. This is a first world problem. We don't see this in third world countries. Why? Nah. We eat too much fast food, we're sedentary, we smoke, all these different types of things. So uncommon in developing countries. So less than 5% under the age of 40. This is an older person type of disease. You have 70% by the age of 85 if they make it to 85. So incidental finding, a lot of times we just do a CT scan and be like, oh, you have diverticulosis, or you have diverticulitis, but ultimately diverticular disease. So natural history, usually benign, doesn't tend to be a big issue, but if it happens in a younger person, you need to be a little bit more concerned that something's going on. Something's going on. So here's how the pathophys works out. They're these small herniations where the vasorecta or vasculature penetrates the colonic muscular wall. That is just a weak spot, so these show up there. Weakest point is where the blood supply is. So if it's true diverticulitis, can involve all 4 layers of the colon, all 4 layers. Versus false diverticular only involves 2. Now, unfortunately, a lot of bacteria is what happens in here. It's in the GI tract. What's in the GI tract? Well, after it's food, it becomes something different. So there's going to be bacteria. So Bacteroides, Peptostreptococcus, Clostridium, Fusobacterium, and gram-negative rods, especially E. coli being the most common of those. E. coli. For you visual folks, here's how that kind of works out. You get diverticulosis on your left there, and then a diverticulitis right there in the middle. And there's just, so if you get a chance to scope, that's how it's going to look. That person did a very good cleanse. A couple different ways that they score that. But just be aware, so typically you see that in the lower left quadrant is where that's going to show up again. If it's in the right lower quadrant, more severe and more likely related to a Beckles. So altered bowel motility, so this puts these people at high risk, typically not enough fiber, so they're going to have this pressures that increase because they're usually stocked up, that type of thing. Smoking, obesity, sitting around the house increases the risk for that. Active lifestyle helps out with that, keeps the gut moving. Plus, there's people that are active, probably burning more calories and making it to the bathroom more often. Different types of things so NSAIDs, opioids, steroids. Obviously, opioids slow things down, but steroids thin them out, and NSAIDs cause ulcerations, leading to this as well. So diverticulitis, left-sided colon disease, they're typically going to come in complaining of left lower quadrant pain, hence the descending colon. So poor bowel, sedentary lifestyle, overeating, constipation, these all play roles in that. So how does that present? Right there, left lower quadrant pain. They can have fever, they can have leukocytosis, but almost always left lower quadrant pain. So it can be constant or it can come and go. There's no particular bowel habits, so they can either have diarrhea or constipation. Just keep in mind, like, oh, they have diarrhea, they can't be constipated. Oh. Anybody ever look at how water flows through a river? If there's a big rock, it just goes around it. So somebody can have a huge stool burden and everything's just going around it. So just be aware of that thing. So usually that leukocytosis is going to be at least well over 12,000. Over 12,000. So other types of symptoms, so nausea, vomiting, anorexia. So again, inflammation inside the abdomen can cause something called sterile pyuria. Sterile pyuria causing urinary symptoms. So what does that mean? Yeah, they're going to potentially have some white blood cells on their inflammation, but if you grow up that urine culture, it's not going to show any signs of bacteria. It's not going to give you an actual bug. So that's sterile pyuria, if you had any questions. That just has to do with the inflammation of the bladder based on what's going on that descending colon. So mild to moderate. So if you can palpate a mass, and keep in mind, these are probably, majority of these people are pretty heavy, very difficult to palpate their abdomen because it's just an obese abdomen, so good luck finding that palpable mass. But if you can, we're worried about an abscess. And this is when we start getting from regular diverticulitis to more concerning diverticulitis that needs to be admitted or potentially needs to be surgery. So if it's stable, similar presentation, Titnally says, they're good, we don't need to do any diagnostic information. That's great, that's the book answer. So, I've had diverticulitis, just give me the meds and send me home. I don't do that. You're getting a CT scan because you're probably older and you make sure that there's no other type of issue, abscess formation or whatever. So diagnostic imaging usually required. I would recommend if you're dealing in the emergency department, it's okay to subject somebody to some radiation to make sure that they don't have something that is going to be life-changing. So make sure we get that. Make sure, because there's other types of issues, and I'll show you in this next slide. So is this a gynecological issue because left lower quadrant pain? Does it go below the umbilicus? Well, now I need to do a little bit more investigating. Is it a cancer? Is it an inflammatory bowel disease in the form of Crohn's or inflammatory, or Crohn's or ulcerative colitis or an infectious colitis? So good differential for you. Differential diagnosis for diverticulitis. So potential for an acute appendicitis. Why? Because we have a Rosing sign, right? Taking me back to one of the first lectures. But just be aware if you've got some other things, ectopic pregnancy, ovarian torsion, you have a woman of childbearing age, or even not. So we're about ovarian torsion versus ectopic pregnancy. Just be aware that there can be a lot of different things. 21 right there that you're thinking, oh, this is diverticulitis, but it could be 21 different things. So be aware of that. What do we want to do? We want to work that up. Laboratory data. Usually not super helpful except for that leukocytosis, but these are going to be labs that are going to help you with diagnosis of exclusion, take a lot of other things off the plate. So urinalysis, again, diagnosis of exclusion. So ultimately, what are we going to order? Contrast abdominal pelvis CT, preferred imaging modality in these folks. So IV abdominal pelvis CT. So make sure that we're going to see the severity of this, especially if they have a history of it, and we'll make sure there's no complications. No complications. Great sensitivity, and if they say there's no diverticulitis, 100%, it's no diverticulitis. Specificity. Nobody's checking on that, right? So again, why do we get the B and P on these folks? I'm going to tell you right now, most of that is to make sure that they can handle the contrast that we're about to give them. Potential compression ultrasound, yeah. We're getting better and better at this, but it's not going to be my first. Why? Because patient's body habitus is probably going to be very obese. It's going to take this off the level. It's not going to really help out. CT, why? Because we want to make sure, did they perf or is there an abscess? Both are surgical emergencies. Both are surgical emergencies. So, uncomplicated. So, that CT says, oh, there's just some inflammation. So, can be with or without a phlegmon. So, phlegmon is just an early sign of an abscess. Can be taken care of with IV antibiotics, but it has not fully formed into an abscess and then complicated. So, abscess, stricture, obstruction, fistula, or perforation. Perforation is bad because now we're dealing with feces where feces is not supposed to be. For you visual folks, this is great. I love this slide. So majority of the diverticulitis is going to end up 3 to 1. So 75% are going to be uncomplicated. So if it's complicated, it's too easy. Make them MPO, surgical consult, blood cultures, antibiotics, EMED. So we want to separate into the well, unwell, the appearing well, uncontrolled pain, uncontrolled vomiting, comorbidities, immunosuppression. We have that 5%. If they fail outpatient, then they need to come in and be admitted for IV antibiotics. You're going to deal with a lot of that with the emergency department. If somebody fails oral antibiotics, it's an easy deal. They need to come in and get IV antibiotics. So 90% of these will be fine on oral antibiotics, bowel arrest, and then what do we do for them later? They need a colonoscopy within 6 weeks. Colonoscopy, go back, make sure everything resolved. So no more radiation for these. So uncomplicated, right there, bowel arrest, oral antibiotics. Most of these people that have this repeatedly know the deal. They usually come in pretty quick. We don't need to do anything crazy with them. So no advantage with this because it's going into the GI tract. We're treating a GI issue. So between IV antibiotics and oral antibiotics, no difference if we're treating uncomplicated. So usually don't have to admit these people, but low threshold to get that CT scan. Low threshold to get that CT scan. So just be aware that there's a growing interest in treating these people with antibiotics at all because they're worried about the side effects. I don't think that's up for your decision. Let's just go ahead and take care of these folks. If you're worried about C. diff, by the way, those people are going to be likely admitted to the hospital. They need to be on IV antibiotics. They're also going to put them on isolation. Okay, be on isolation. So complicated though, IV antibiotics, bowel arrests. So just be aware we got this thing called the Hinchy classification. That's going to break down. They should give you a Hinchy classification on that CT scan. The radiologist should give you what category they are. What category they are. Obviously, the higher the stage, the worse it is. And that's going to give you an idea. So if they're at stage 1, about a 3% mortality. So 3%. If they are at a stage 4 of free perforation, 43% mortality. That's not good. That's almost 50% of the people that are going to pass from that. So most common complication, abscesses and phlegmon, which is early abscess. So there's potential they can do percutaneous drainage with that. Percutaneous drainage, abscesses that are under 3 centimeters. Hinchy 1, often admitted with IV antibiotics, do not require any type of instrumentation in their abdomen. Whereas if they perforate, yeah, that's going to be an XLAP. Exploratory laparotomy. So open from usually manubrium all the way down below the umbilicus, suprapubic area. No fun, no bueno. So uncomplicated diverticulitis, these people can go home provided they have stable vitals, they're non-toxic, got their pain under control, and you hardly have any physical exam findings. So they need to make sure they take their antibiotics, clear diet, and they take their antibiotics until they are finished. So admit these patients, obviously we can't get them PO tolerant, they can't go home, they have a lot of comorbidities, they don't have a good social network, and you have a significant leukocytosis, and I will base that if I have a leukocytosis above 16, I'm not sending that person home. You'll figure out where your line in the sand is. Anything above 12 is abnormal, but above 16, I'm not okay with that person going home. So high fevers, elderly, obviously are immunocompromised for whatever reason, those people should not go home, and we can't get their pain under control. So chronic steroids puts them at higher risk of perforation, so be very aware of that. And if they're immunocompromised, admit those patients that have failed outpatient or if they are in the complicated category. So again, within 6 weeks, if that has not resolved, that is a reason to bring somebody in as well. Young folks, anyone under the age of 40, very concerning that there is something else that's going on. They have higher rates of recurrence, they have higher complication rates, they require surgical intervention more, which we already talked about. We have a bunch of surgical intervention that we're dealing with a lot of instrumentation in the abdomen. Now these people are also at higher risk for small bowel obstruction. Gives you even more reason to get a CT scan. There's your Meckel's diverticulum. Again, we can get a Meckel's scan, that is red tag scintigraphy. So you got the rule of twos. So 2% of the population, 2 feet from the ileocecal valve, which the ileocecal valve is in the right lower quadrant. So, and symptomatic in 2% of patients. So abdominal pain, usually younger folks. There's your radionuclide imaging. It is a nuclear medicine scan. That treatment is required for surgical. Yes, it can mimic because it's in the right lower quadrant, can be confused with appendicitis because we're filling that demographic of a younger patient. So this is an interesting thing. I didn't even know this was a thing until, and I got down here at BAMC in 2019. And CT scan came back as epiploic appendage. I was like, what the heck is that? So these are just small fluid-filled sacs in the lining of the colon. They twist on themselves, they torse, they cause a lot of pain, and they essentially die, and it's not a big deal. You just got to treat the pain of that. So sharp pain, abdominal pain, this will say that on the CT scan that this is what's going on. You treat that. Be careful giving too much narcotics, because then you're just going to give somebody constipation from slowing their GI tract. But incidental finding, these are benign in nature, but they can be very painful. So pain management, make sure they can follow their primary care. And if you do give them narcotics, make sure you give them stool softeners. If you're sending somebody home with narcotics at any point, please send them home with stool softeners. All right, we'll do check on learning and we'll finish up for today. Questions on diverticulitis? Keep looking over there like it's going to work. So we made sure that we did a good exam of the genitals because it's left lower quadrant pain below the umbilicus. Please don't make that mistake. You're going to miss something and you're going to get your feelings hurt at the expense of a patient. We don't roll that way. CT with IV contrast, correct? Diverticulitis C. Does this patient go home? Absolutely not. Everybody agree that we're going to go with B, right? We're going to start the antibiotics, but we're going to talk to general surgery and let them make the decision. I don't tie their hands. I mean, I know that guy probably needs surgery. They're not going to do percutaneous drainage unless it's less than 3 centimeters, but I'm not going to tell them how to do their job. I'm just going to say come down and take care of the patient. I know what the right thing is. I know what they're probably going to do, but I don't want to tie anybody's hands. This is the book answer. Yes, oral antibiotics. No difference between IV. It's uncomplicated diverticulitis. Complicated, stay centered. Alrighty. Give you guys a little extra time for your lunch because you're